Hello and welcome to a Medscape Oncology live stream. My name is Eric Singhi. I'm a thoracic medical oncologist at the University of Texas MD Anderson Cancer Center. Honored to be here with all of you today. I'm joined by my dear colleague, Dr. Wakelee, if you'd like to introduce yourself.
Hi, I'm Heather Wakelee, Chief of Medical Oncology at Stanford University and Deputy Director of the Stanford Cancer Institute, and it's great to be here and to be talking with you, Eric.
Absolutely. So today we're going to be focusing on a turning point for our patients with HER2-positive non-small cell lung cancer. Specifically, what do clinicians need to know right now? So let's get into it. So let's talk a little bit about HER2 alterations in non-small cell lung cancer. Not all HER2 alterations are the same, so it's important to really understand what we're talking about. What is the language? So we have activating HER2 mutations. They're found in about 2 to 4% of patients with non-small cell lung cancer. We need to be checking all of our patients using things like NGS-based assays. PCR is also acceptable looking for these HER2 mutations, but they're found in more predominantly in patients who are females, of Asian ethnicity, have no prior smoking history, and with adenocarcinoma, but it doesn't mean we just stop there. We need to be checking everyone. We also have HER2 amplifications. The frequency really varies based on if it's a primary driver. It can occur in about 3% of cases, or it can be an acquired mechanism of resistance. For example, if a patient has been exposed to EGFR TKI, and that's in about 13%. And to check for HER2 amplifications, the gold standard is to use FISH testing, and that's on tissue. And then we finally have HER2 overexpression, which we define as 3+, very strong intensity. And that's found in about 2 to 38% of patients. It's more common in well-differentiated carcinomas, and we detect that using IHC testing, again, on tissue. For today's talk, we're really going to focus on activating HER2 mutations. Again, we can use tissue or liquid biopsies and NGS-based assays to identify those mutations. When we think about activating HER2 mutations in non-small cell lung cancer, 50 to 60% of those are going to be in the TKD, tyrosine kinase domain. So this is a critical region of the HER2 protein that plays a really key role in its function. The most common is the YVMA insertion and the exon 20 insertion. Tends to be mutually exclusive with other oncogenic drivers, but it is associated with more of an aggressive biology. There can be a high likelihood of things like brain metastases. So CNS surveillance is a really important component, and we'll talk about that a little bit more throughout our discussion today. So how do we test for HER2 mutations in non-small cell lung cancer? We keep mentioning NGS. NGS stands for next generation sequencing. Really recommend comprehensive testing with a broad panel. And these are guidelines consistent with all of the really major organizations, NCCN, ASCO, ESMO. And we really want to be doing that for our patients with advanced non-small cell lung cancer, not only if they have no smoking history, not only if they're female, but truly all of our patients who are presenting to us in clinic. With that, I'll hand it off to you, Heather, to talk a little bit more about current treatment strategies.
Thanks, Eric. That was a great overview, and it's just so important that we're testing. We don't look, we don't find it, and so important. And so, at this point, if someone is newly diagnosed with metastatic lung cancer, and we find one of the HER2 mutations, first line is still platinum doublet chemotherapy, and I usually think about giving pemetrexed as the doublet just because it's been so effective, even before we had any targeted agents. Some people recommend using a checkpoint inhibitor. I tend not to. I really kind of think of this like I think about EGFR, where the responses to a checkpoint inhibitor have been kind of low. So I just give a platinum doublet first. And then the second line approvals, we have had trastuzumab deruxtecan, also called TDXD, for a little bit of time with good efficacy, and we'll go through some of that details in just a moment. We also now just got approval with zongertinib. So this is the first oral medication, first TKI. And so that really has been a game changer in this disease. We have the trastuzumab emtansine, TDM1, been around a little bit longer. And so it's something that some of us have familiarity with. Definitely have seen some responses there, but it's not as good as the trastuzumab deruxtecan or now with the zongertinib, but it can be something that can be thought about even later lines. There is some data that when you're dealing with these antibody drug conjugates, sometimes you can actually get responses when you're bringing in that different toxin. That's the drug part of the conjugate. So you can use that sometimes after even the trastuzumab deruxtecan. So that remains an option, or trastuzumab alone sometimes with some of the chemo partners. So how do we think about this data? Well, the great news is that with both the trastuzumab deruxtecan and the zongertinib, we've seen really high response rates. So those can be 50, 60, 70%, depending on which of the trials you're looking at. For the zongertinib, we have to be mindful that if a patient has already had a HER2 targeted antibody drug conjugate, the response rates are a little bit lower, quite a bit lower. With untreated, it's closer to like 70%, untreated by any HER2 targeted agent, I should clarify that. When we're thinking about the trastuzumab deruxtecan, many people in the audience are probably familiar with this drug from its use in breast cancer. There, the dosing is a little bit different. In lung cancer, the dosing that has been recommended is the 5.4 dosing. And that's based on a comparative trial looking at the 6.4 versus the 5.4 milligrams per kilogram. And that 5.4, you still were getting very high responses, a long duration of response over a year, but less toxicity. And that's been one of the challenges with this agent, are the toxicities. We worry a lot about pneumonitis, of course, in lung cancer, and that is something that can be seen. At that lower dose, it's less frequent, but it's still something people need to be really mindful about. Otherwise, the drug has been reasonably tolerated. We're still giving chemotherapy, and there's still some of the chemotherapy side effects. When we think about the zongertinib, it's an oral medication, makes it a lot easier. Again, the response rates have been quite high, close to 78% in patients who haven't previously had a HER2 ADC. And again, with the durability of response, it's about over a year, which is fantastic, right? That's what we really want to be looking for. And then I always think about that, then how do we decide? You got to look at that toxicity also. Here we're getting more of the GI side effects. So there's some LFT abnormalities, some issues of diarrhea, some nausea, dry skin, but less of the pulmonary toxicity, which is something that we worry about with the antibody drug conjugates, of course. So it's wonderful that we now have options that we never used to have before. It also makes it a bit more complicated when a patient with a HER2 mutation comes into clinic, and I've had a couple just in the last couple of weeks where they're asking a lot about zongertinib and when can we use it, and what about the trastuzumab deruxtecan, and how to sequence all of those. And it's a really exciting time and complicated, and it's going to get even more so because there are many other new agents in development. I think one that we've seen a bit more data about is the cevabertinib. That one's still not available yet, but also looking pretty encouraging, a lot of similar numbers. Maybe, toxicity is not that different. I think that's been a challenge in the past with some of the earlier HER2 targeted TKIs, just a lot of GI toxicity, and the zongertinib is much better tolerated than those earlier drugs. So it's exciting to see a lot happening, many other agents in development too. And I think this is going to be a very rapidly evolving field now that we've been able to sort of break through the toxicity challenge that had been such a problem in the past years. And then that gets us to kind of the big question, which I'm going to turn back to you, Eric, and that's, how do we make treatment decisions with our patients? How do we talk through this data? How do we make decisions about which agent is the right for an individual and at what time course, right? So how do you think about that?
Yeah, no, excellent summary of all the data we've had so far. And it's really an exciting time to be a thoracic medical oncologist and to care for patients with lung cancer, because we are identifying these biomarkers. We are coming up with solutions, not only infusions, but oral therapies that can work really well and allow for patients to spend more time outside of the confines of clinic and the infusion center and things like that. And so really excellent discussion. Super excited that we're having this discussion really fresh off the recent FDA approval just last month of zongertinib, right? Yeah. You're absolutely right. Like, how do we make these decisions in clinic? I think one of the big things to talk about with patients is make sure they feel educated and counseled regarding potential toxicities and side effects, which you really nicely summarized. That ILD pneumonitis risk with trastuzumab deruxtecan, it's real. It's not as frequent, thankfully, with the lower dosing that we've been giving now, but it can still be real, especially there's a risk if patients were to receive that soon after receiving immunotherapy. If they got that in the first line setting, we need to be thinking about these things, how we sequence treatments. And if you've experienced it and you've experienced it with your patients, you know it can be challenging. And so I am absolutely thinking about that risk. What's reassuring is that zongertinib does not appear to have that ILD pneumonitis risk, which is exciting. Same with many of the other oral targeted therapies that are evolving in that landscape. So thinking about that toxicity, thinking about liver toxicity, with zongertinib, we do have to watch the liver enzymes more closely. And then with trastuzumab deruxtecan, you summarized it really nicely. This is almost a smart version of chemotherapy, right? We're hoping for that bystander effect to really direct a high cytotoxic payload to the cancer cells. But there are still those chemotherapy side effects. So the nausea, the cytopenias, the alopecia, all of those things are real that we have to make sure patients understand and buy into. So yeah, thinking about those toxicities and then thinking about the time toxicity component, which we've hinted on. How much do patients want to be in the infusion center, show up every 3 weeks for their infusion versus taking their pills at home with options for virtual visits and follow-ups from that toxicity check standpoint? I think that's a nice option. I think another nice point highlighted on this slide is clinical trial availability. We don't yet need to wait until a patient unfortunately experiences disease progression to start talking about clinical trials. We're going to talk about some in just a minute here, and I'll have you highlight them. Really exciting potential first-line options to bring these drugs to newly diagnosed patients with HER2-positive lung cancer. But yeah, what about you? How are you digesting and unpacking this in clinic right now?
It is tough. And I think with every patient, it is important to have these discussions about these options. Definitely have a lot of people asking, why can't I do this first, right? Where we just don't have those approvals. And of course, we do have the randomized trials, which are ongoing, actually, I think probably finishing enrollment, looking at the trastuzumab deruxtecan versus chemo, the zongertinib versus chemo. And so as those results come forward, we'll hopefully be able to get approvals to get those agents before the traditional chemotherapy, though keeping in mind, carboplatin pemetrexed does tend to work pretty well in this patient population. And, we all know that toxicity and how to manage it. So, but if you can get something that works more of the time and for longer first, that's of course much better for our patients. If both of those trials are positive, it's going to be, which I expect they probably will be, it is going to be a little tricky then because they're not comparing head to head, and I don't know that we'll ever do that. And so then it's going to be all right, what are the other things? Well, what's that durability of response? Is it similar, right? That becomes very important. And the toxicity question, which I think, again, you've highlighted very, very well. I think from a patient tolerability standpoint, most people are going to think about the oral medication. We also need to think about the CNS protective effects. And, that will emerge more in these randomized trials to be able to really think about what that looks like and if there are differences there and what that means. I've also heard conversations about combinations, right? And, maybe we'll be seeing those too, depending on how the toxicities pan out. And then again, there's so many other drugs moving in, and how will that look like in the first line? Probably they'll have to compete head to head with other targeted agents in first line in the future. And we need to understand more about some of the resistance mechanisms. There has been some data, but it's still a lot of opportunity to better understand that as we then think about the sequencing of the future. So, just so much there, so much to think about. And then other stages of disease, right? That's the next wave that always comes once we've got something proven to work well in first line. What about bringing it into perioperative setting? What about chemoradiation setting for the more locally advanced disease, right? We don't have answers. And I think a lot of us are getting those questions already from our patients.
Yeah, no, I think that's a really good point, especially since we've been able to now develop an oral targeted therapy that seems to have manageable toxicity and tolerability. Can we be moving this forward into those earlier stage settings? I think is a really important question. We have data from the EGFR space, that tells us that yes, we should be doing this for patients. So one can imagine that is moving its way forward, and hopefully we'll continue to get more answers. And I'll echo what you said too about just the CNS efficacy and duration of response there. That's going to be huge. It's such an unmet need for these patients because unfortunately with this specific driver alteration, many of them throughout their treatment course and disease course will develop brain metastases if I don't meet them for the first time in clinic with de novo metastatic disease in the brain.
Right.
Looks like we have a question here, actually, Heather. I'll
Okay.
ask you this one. If a patient has poor performance status and has a HER2 mutation, the choice can be frontline TDXD, or should we start with immunotherapy alone? What do you think?
A really good question. I really, I don't think that the immune therapy works particularly well in patients with this driver mutation. I really do think about them as being more similar to patients with an EGFR mutation as far as that efficacy. There are a handful of patients who benefit, but it's really not the same as patients without one of those driver mutations or with like a KRAS mutation. So I would not start with immunotherapy alone. If you can get the trastuzumab deruxtecan approved first line, that is certainly an option. It's still chemotherapy. If they're particularly frail, I might even think about pemetrexed, where we have a lot more efficacy data and a lot of safety understanding. I think that without that pneumonitis risk, because that's the one thing that we do need to be mindful of. And if someone's already pretty frail, if they do end up with pneumonitis, they might not be able to tolerate that as well. And it's still not approved first line. So I think depending on the frailty of the patient, pemetrexed with or without the platinum, probably with, maybe at lower doses, would probably be my favorite choice. I don't know, Erica, if you have different thoughts about that.
I've been in a similar situation as well,
Yeah.
too, and what we did was single agent pemetrexed. But if you can, and hopefully in the future with more data, we'll start to see and hopefully see that more of these targeted agents are moving forward. Those would be very good options to pull, but you're exactly right. Right now, we don't have that approval.
Right. But perhaps with the positivity, I mean, zongertinib, because of its tolerability profile, might end up being a good first line option, but we just don't have that possibility yet. So
fantastic. Well, thank you all for joining for this Medscape Oncology live stream and for participating in the activity with us. To earn your credit, you can enter the URL below on your personal device. Again, my name is Eric Singhi. Thank you for joining, and thanks for being here, Dr. Wakelee.
Thank you. It's been wonderful.
Take care.
I'll be with you. Thanks.